All right, well, welcome everyone. This is the second in a series of webinars we're hosting in collaboration with the Louisiana Department of Education. And I'm Peter Katzmarzik from the Pennington Biomedical Research Center. And I just wanted to take a brief moment to welcome everyone today. I know we've had a rough couple of weeks here in Louisiana, and I'm glad to see that we've got a number of participants here today who are interested in this topic. We will be recording the webinar and it will be available later, so we can distribute it to the group and to those who were not able to make it today. We want to be very interactive today, so we'd like to encourage you to use the chat for submitting questions. And then Dr. Whitfield at the end will have these questions available to him to ask the presenters along the way for the live Q&A, which will follow their presentations today. So with that, I will turn it over to our moderator, Dr. Whitfield.
Thanks so much, Peter, and hope everyone out there is doing well and is safe. As Peter said earlier, we had a pretty interesting, rough couple of weeks here in the state, and we have some rain coming from Hurricane Nicholas. So hopefully everyone is safe and sound. And if I inadvertently disappears because I'm losing power off and on with the power grid in my area due to this weather, and so I will be logging back on. But guys, I hope you're again safe and well. This is a very special topic to me, and I'm not speaking just as a physician, but I'm speaking also as a father of a 3-year-old and a 16-year-old who's in high school here in Baton Rouge, Louisiana. And that topic we're going to be going and delving deep into today deals with school lunches and healthy nutrition and meals at our schools. And you know, school nutrition is critical to the health and well-being of our students, especially the lower income students who don't always have access to healthy meals at home. And so we want to ensure that our students not only just have healthy nutrition, but the education that goes with it to make sure that they develop healthy habits that would extend on into their adulthood. You'll hear many physicians quoted and say that an obese child makes an obese adult, and childhood obesity is on the rise in our country. And you couple that with the pandemic that's currently going on in our country, we have a lot of challenges and issues that need to be addressed. So since our children spend the majority of their formative years in school, I think it makes sense that parents, teachers, physicians, that we all be on board and want these young people to have the healthiest options available to them to help them focus better in school and perform well. Even when speaking to some of my student athletes, not understanding how important nutrition is to their performance on the field, as well as if you're performing on the field and you're burning those calories in nutrition, how that correlates or translates over into healthy living and lifestyles and performance in the classroom. And so we have some very awesome panelists that are going to speak to you today. I'll first tell you their names, and then we're going to have some brief remarks from the Department of Education, Mr. Dupree. Coming first is Dr. Christina Economos. She's an expert on whole of community approach to obesity interventions and how a system approach can turn the tide of obesity. She was the principal investigator of Up Somerville, a CDC-funded project believed to be the first controlled experiment demonstrating the value of a community-wide effort to prevent obesity. The Up team developed and implemented strategies designed to create energy balance for first through third graders in Somerville, Massachusetts. In before, during, and after school environments, interventions were focused on increasing the number of physical activity options available to children throughout the day and on improving dietary choices. In fact, the intervention with the kids helped the parents lose weight too. So again, correlates with sometimes what the child does, it could influence what the adults do as well. So Dr. Economos, we appreciate your research and help with that. Next, we have Dr. Darius Mazafar, I'm gonna mess that last name, Mazafarian, a cardiologist who's also the Dean of Nutrition at the school at Tufts. He and his colleagues published a paper in JAMA, Journal of American Medical Association, in April of this year. The results related to where Americans get their food are significant. So in other words, where you get your food is very significant. Schools are the single healthiest place Americans are eating. Very powerful statement. I think this may be true for Louisiana too, he says. So we'll welcome Doc as well with his insight. And Dr. Robert Weaver from the University of South Carolina will complement all of our guests from Tufts quite well. He will bring his expertise in physical activity, recess, and after school programs to the panel. He also has experience in how changes in food quality and cost affect food consumption. So again, a great panelist of individuals to speak to you all today. And before we get started today, we will have some brief remarks from John Dupree from the Louisiana Department of Education.
Hello, my name is John Dupree. I'm the State Director for Child Nutrition Programs in Louisiana, where I've served in that position for the past 24 years. On behalf of the Louisiana Department of Education and Pennington Biomedical Research Center, I'd like to welcome you to our webinar series. Since 2015, these agencies have collaborated on the Louisiana Fit Kids project. This is an effort to provide access to high-quality information, training, and resources to child nutrition program providers such as schools and daycare centers across the state of Louisiana. Louisiana is well known for its people and its culture, and part of that culture is its wonderful food. However, the last several decades, Louisiana has consistently ranked among the worst states for the rates of childhood obesity. We want to provide the best future for our children possible. That includes having as wonderful a childhood experience as possible. But we know that without our health, it is fully difficult to experience the wonders of growing up into young adulthood. And the behaviors we develop during our youth generally carry forward into our adult lives. So through this webinar series, we hope to provide clear, current, and unbiased information about childhood obesity to help those who provide care and education to children and who help to shape their present and future lives, to help us all gain a better understanding of the issues and how we can help be part of the solution.
Thank you so much, John. And we'll go ahead and start our presentations at this time.
Hi, I'm Chrissy Economos, Professor of Nutrition at the Friedman School of Nutrition, Science, and Policy at Tufts University. And the title of my talk today is Equipping Communities to Address Childhood Obesity, a Systems Approach. So starting with the prevalence of childhood obesity, you can see here that over the past 50 years, from the mid-1960s until the past couple of years, the rates of obesity in children have nearly tripled, beginning at about 5% and rising to almost 20%. Stratified by age, you can see that the rates are the highest in the 12 to 19-year-olds, which is slightly above 20%. If we look more closely by race and Hispanic origin, these data are for 2 to 19-year-olds over the past 20 years, and you can see that overall rates have been rising in all groups except for non-Hispanic Asians, and the highest rates can be seen in the blue line, which represents Mexican American children, followed in the yellow line by Hispanic children, in the orange line by non-Hispanic Black children, and then in the green line by non-Hispanic white children. And so when you look individually by race and ethnicity, you see very dramatic disparities, where the rates in the Mexican American, Hispanic, and non-Hispanic Black children are approaching 25%. And this is important when we think about designing interventions, not to go into a particular community and just assume that the overall rate is the average, because it can vary dramatically, as you see, between 15% and 25% for different groups of race and Hispanic origin. These data demonstrate what appears to be going on as a result of the COVID-19 pandemic. So these are pediatric BMI changes during the COVID-19 pandemic using electronic health records and looking at children who came for at least 2 well-child visits over a period of about 5 years. And what you see on the y-axis is the change in BMI plotted against time. So for 2 different visits, how did a child's BMI change? And it was fairly consistent, although it was rising a bit between January 2017 and January 2020. But you can see for children who came in post-pandemic and throughout 2020 that the change in BMI was actually much higher, demonstrating that there was weight gain, which was probably unnecessary or undesirable weight gain in many children throughout the pandemic. This was actually the highest in children who were about 8 to 12 years of age. These are also data representing what was likely happening during the COVID-19 pandemic with respect to childhood obesity. These are data from a smaller group of children who had BMI Z-score measures pre and post-pandemic school closure. So in the dashed line were children who had pre and post measures starting in 2017. And then as soon as the pandemic stay-at-home orders happened, you can see the dark vertical line sort of cutting. And then the children on the right were measured after the pandemic had started. And so for those children, you can see a rise in BMI Z-score, which looks very similar to the change in BMI that we saw in the last slide, again suggesting that there was additional weight gain over and above normal growth and development that we're seeing in many children. These data look a little bit deeper at weight-related behaviors in children during COVID-19. So in other words, what's underneath that weight gain? What might be explaining why we're seeing this? So on the left panel, you see movement behaviors or physical activity represented as sedentary behavior, light behavior, and moderate to vigorous physical activity behavior. And on the right, you see dietary intake stratified by healthy foods and unhealthy foods. And what you can see on the left with movement behaviors is that sedentary time appeared to go up, light activity went down, and moderate to vigorous physical activity, which was very low to begin with, also went down a bit. And on the right, you see the consumption of unhealthy foods went up, whereas you also see healthy foods going up, which might suggest that children were overall eating more and the new contribution of excess calories was coming from unhealthy foods. So taken together, there appears to have been a change in both physical activity and nutrition that might explain the underlying weight gain during the COVID-19 pandemic. There are more data that are coming out on a daily and weekly basis, helping us understand what's happened over this last year and a half and how we need to respond with programming and policy. So we know obesity is a very complex system. And as you see here in this very complicated map put out by the Foresight Group in the UK, there are lots and lots of variables that are categorized here as social psychology, individual psychology, physical activity environment, individual physical activity, physiology, food consumption, and food production. And within each of these clusters, there are variables that are all impacting what you see in the middle there, which is the energy balance loop of an individual and the regulation of how we manage weight. And that can be impacted by many, many different things simultaneously. So it's an incredibly difficult problem to study and a problem that is very, very hard to intervene upon because one single intervention is unlikely to have a great impact. So we know this is a complex adaptive system due to these varied interacting and emerging factors within and between individuals and their environments that influence the balance between energy intake and energy expenditure, or what we call energy balance. So I want to talk about how we can begin to think we can reduce obesity rates in America and what types of interventions have been done. So my own thinking about the evolution of obesity prevention research is that there started out being a lot of individual behavior change interventions about 20 or 30 years ago, targeting the individual with very controlled settings. It gives us a good sense of a dose response. It tells us the efficacy of a particular intervention, really important, but hard to translate into the real world. Then we started to do more policy and environmental interventions to try to re-engineer our communities and reshape the environments in which children live in order to execute those healthy behaviors. And those are really important, although if they're just being implemented singly or without a coordinated action, it's hard to impact individual change. Then we started moving toward multi-level, multi-sector designs, involving a lot more people, really appreciating the complexity and the interaction, and getting people to work together to implement these policy, environmental, and individual behavior change strategies. And last but not least, we've evolved within the field to really think about whole of community system science approaches. This is the type of approach that I take in what I'll be talking about today. So before I do that, I want to emphasize that it's important to get to equity. As I showed already, there are stark disparities in obesity rates by ages, by race and ethnicity, also by geography. Children who live in rural areas have the highest rates, followed by urban, and then the lowest rates are seen in suburban settings. And this is a function of access, socioeconomic status, and many of the things that you're seeing in this framework here that was developed by Shariki Kumanika. So what you see here are on the top, increasing healthy options and reducing deterrence to healthy options are things that we often think about with respect to food and physical activity, availability and access, like food retail provision, built environment, transportation, promotion of unhealthy foods, threats to personal safety, social exclusion. These are things we really need to continue to work on and implement within large community settings. But in the bottom, we're introduced here to social drivers like improving social and economic resources and building community capacity. And things within these two quadrants are really what we think about as social drivers or social determinants or the underlying factors that might be driving an unhealthy environment. And we now understand if we don't tackle things in these quadrants and take a whole of community systems approach, we're unlikely to have an impact on individual behavior and weight, and particularly an impact that is sustained over time, because we need to be thinking about a comprehensive change to society in order to create equity and lower the rates of obesity. So we take all this into consideration when we do our whole of community interventions. So these data are from the Healthy Community Study, and they're important because there were 130 communities in this study, and what they did is examined retrospectively what had happened in these communities that might have led to a reduction in BMI in children and even keeping the obesity and overweight rates relatively low in the communities. And in the top, you can see they created a score for community program and policy interventions ranging from 0 to 80. And on the x-axis, you can see time from 2004 to 2014. And what you see is over time, many of these communities were indeed implementing more program and policy and environmental changes that increased their score. And then they took that score and they plotted it against changes in body mass index in children. And you can see here that the greater the score on the x-axis, the more likely it was to see a reduction in BMI Z-score, showing us that relationship between making those large environmental and policy and programming changes and the impact on the individual. So this tells us a lot about the need to continue to implement policy and programming in communities, and that over time it does make a difference. So what are the types of things we need to think about with respect to policy and programs? Many of the things listed here have been shown to be evidence-based, have been effective in both smaller trials as well as community-based trials. And I want to go through them because if we were able to implement all of this simultaneously, it's highly likely that we would have an impact on children's health. So we know promoting breastfeeding and responsive feeding early in life is very important to helping establish regulation to hunger and appetite and developing healthy habits very early, as well as exposing an infant to the positive benefits of breastfeeding. Reducing and eliminating sugar-sweetened beverages and increasing water, getting healthy consumption of fluids early in life established. Reducing ultra-processed foods, red meat, and added sugar, or foods to discourage, while increasing whole grains and fruits and vegetables, or foods to encourage. Establishing structured eating as much as possible in family meals. We know that children who are out of school have less structured eating, particularly during vacation time and in the summer. And while they're in school, the structured eating and structured physical activity is shown to be beneficial in terms of controlling how much is eaten and when food is consumed. Physical activity every day in all settings, and that's requiring physical education and opportunities for physical activity in schools, promoting recess and activity breaks, and developing and implementing safe routes to school plans so children can use active transport to get to school. Limiting screen time, and particularly screens in the bedroom. Continuing to work on our National School Breakfast and Lunch Program, the WIC program, and the SNAP program, where we continuously improve standards and access to these fantastic national programs. Implementing menu labeling and portion control, particularly with food away from home, as we're spending more than 50% of our food budget now away from home. Taxation of sugar-sweetened beverages, and that's happening in many communities and is shown to be beneficial. And last but not least, increasing community engagement, capacity building, and diffusion. And I'll talk quite a bit about how we diffuse all of these strategies throughout a community and increase uptake and sustainability. So before I move forward, I want to go backward and talk about an intervention that we did from 2002 to 2005 called Shape Up Somerville. And Shape Up Somerville was designed to increase energy expenditure of up to 125 kcals per day beyond the increases in energy intake and expenditure that accompany growth. And this was really designed to be whole of community and to take the evidence at that time, which was shown to be effective, and put it together in a portfolio and implemented community-wide. So we focused on physical activity, screen time, foods to encourage, foods to discourage, and then the structure piece around family meals. And we took a multi-level approach, so we implemented these strategies before school, during school, after school, within the home and the community at large. And Somerville is a community in Massachusetts where we then took 2 other communities that were socio-demographically matched and had them serve as controls throughout the intervention period. And these are the results of BMI Z-score at 4 different time points, so before and after the school year for 2 consecutive years. The intervention trial is seen with the diamonds, or the second line down, and you can see over the first school year, there was a decrease in BMI Z-score, a little bit of a blip in the summer, and then a decrease again. So from beginning to end, there was a reduction in BMI Z-score, whereas in the 2 control communities, there was actually an increase in BMI Z-score when you looked independently or if you combine them, which is seen in the line that's dashed with the circles, which a priori was the study designed to compare the intervention versus the combined controls. So this shows us that with a whole of community intervention effort, where you implement a portfolio of evidence-based strategies, you can actually see a reduction of BMI Z-score over 2 years. So underlying the change, we looked at lots of different behaviors and policies, and we saw not only a decreased BMI Z-score in the children, but spillover with the parents, where there was a reduction in obesity prevalence in the parents who were in the intervention community. We saw a reduction in sugary drink intake and screen time, and an increase in the return on investment, which I'll show in the next slide, as well as sports, physical activities, healthy restaurant meals, healthfulness and quality of school food and competitive foods, community-wide policy change, and increased food access through additional farmers markets and gardens. And I'm pleased to say that all of these activities have been sustained to date and have even grown more in this community, and that has informed national efforts. So these are the return on investment data, where you can see that at first it does cost money, and this is in 2014 dollars, but at about the 6-year mark, it starts to pivot where you see a return on investment. And these data are from this trial where we looked at the productivity and healthcare costs of the children and parents over this time horizon, demonstrating that you do need to invest up front, but there is a substantial return on investment and payback if you stay with it over time. So the other thing we really wanted to examine was underlying the portfolio of evidence-based strategies that were implemented. What were the community dynamics, or how did we actually get these things implemented? So we used system science to develop this map, which illustrates the different microsystems that were at play during the intervention and which things ultimately led to the individual behavior change and weight change that you see at the top represented in blue by the individual. And in looking at this map and doing this analysis, we realized that the Shape Up Somerville Task Force, or the multi-sector coalition that we put together at the beginning, was critical to diffusing the strategies and implementing the intervention that had the effect. And we started to study the dynamics of this more and more, so we understand this upstream group or coalition and how they're working together and within the community to actually make change happen. It can't be the investigators that create the change. It needs to be stakeholders who know the community, who work in the community, who are invested in making change. So we also took a look at the literature and wanted to see how many community-based obesity prevention trials had engaged coalitions in their work. And we found almost a dozen studies that had done that. and we looked at the results and categorized them as positive outcome, mixed outcome, null, or negative. And we plotted that against the number of community engaged research phases that were at play with the coalition. And you can see that the more phases that were in play, the more that there were positive effects shown. This is just an association, it's not cause and effect, but it's really meant to illustrate that it appears the more that the community is actually engaged, the better. And so moving forward with all our trials, we're making sure that the number of community engaged phases is as high as it can be. So for transforming communities to prevent obesity using a systems approach, we know that at the community level, there needs to be comprehensive whole of community transformation that supports healthy eating and active living through systems, environmental, and policy change in wide-ranging places. So what we do is we leverage innovative approaches from system science to bring together cross-sector stakeholders who form a coalition and participate in structured activities that surface their diverse perspectives, build consensus, diffuse the evidence, and drive coordinated, comprehensive action. And through this process, we evaluate rigorously and we continuously refine the approach and advance the field of obesity prevention broadly by publishing and disseminating our findings. And we believe that the responsiveness to local needs and community readiness are really key priorities, so we adapt our approach to each community with which we work. So this is a theory that we've developed called stakeholder-driven community diffusion. And I intentionally put a black box around one section of it, which I will show you in a moment. But the reason is because most people just hand policy, practice, and environment instructions to child health champions in a community and hope that it impacts child health outcomes. It's not as simple as that. It's quite complex. There's a lot of dynamics and relationships at play. And this is why we work to the left here, upstream and midstream, to make sure that we're engaging the right people and diffusing the evidence through them, helping them prioritize and act according to the readiness of their community and the context that they're working in, so that the correct policies, practice, and environments can be shifted. So we begin on the left by convening, and we convene a group of stakeholders, generally about 15, who are leaders in the community and who are multi-sector, and agree to work with us over a period of 1 to 2 years. And it's simply represented here by showing 4 community groups, but we would be working with 12 to 15. And you can see that in a typical community, there are people interacting across groups, but generally they're interacting within groups. So we take, as you can see here, for example, about 5 people from these different groups, and we bring them together to form this coalition. And then they begin to work together and exchange information and ideas. And you can see the circles are represented in blue here to go from less knowledge to more knowledge. One of our goals is to deepen and increase knowledge as we work with these groups over the 1 to 2 year period. The other variable that we measure is called engagement, and both of these are measured through a tool that we have developed and validated, which has many different constructs and gives us a score of knowledge and engagement. Then we bring this group to through a series of activities to increase their systems insights and build their knowledge and relationships using something called system dynamic or group model building. This shows what group model building looks like in action. There are people sitting around together with paper and pens actually modeling. So in this case, they were going through a series of activities, looking at hopes and fears and connection circles and priority setting, and really trying to map and understand what their unique community looks like and what different variables are interacting together. There are feedback loops that occur, there's a time element that they consider, and they really begin to understand where they're working and what they need to prioritize in terms of intervention strategies. And they develop at first something called an informal map, which looks like this. And you can see the positives and negatives, which are feedback loops, and how things interact with each other. And you can also see that, for example, many things in the map on the left are leading to the development of the prevention of obesity. We then use a computer program to take these informal maps and display them with what you see on the right, with balancing loops and reinforcing loops. And then we take them and we color code them and put thematic clusters on. So in this case, it's drivers and impacts of childhood obesity in Cleveland, Ohio, one of the places where we've been working. And you can see that their map ended up focusing on nutrition assistance programs, food access in the environment, the community environment, school environment, and organizational priorities. And then within this, they go deeper and select a few things that are key leverage points that they're going to work on over a period of time. These informal maps can also become formal models with computer simulation, where over time we can actually forecast or predict what might happen if we put certain interventions together. And this can help communities plan more and anticipate and choose the right portfolio of interventions that will have the maximum impact. We then try to help them diffuse and collaborate using something called agent-based modeling, which is another forecasting tool that we use. So in this case, what you're looking at here is a particular community where we simulated knowledge and engagement change and the diffusion of that by doing an actual intervention and then using the baseline variables to simulate what would happen. And what we saw is that we can successfully reproduce observed patterns in community knowledge and engagement. Again, another way to forecast what might happen and to plan the series of activities that we do with the community to actually increase their knowledge and engagement even more. What we also know is that one size doesn't fit all. It's a combination of community context and intervention activities that determine the outcomes. So one of the ways that we help diffuse and measure that diffusion is through social network analysis. So once the communities prioritize and act, they then diffuse these things throughout the community. And we measure using stakeholder networks. And in this case, you can see in one community where we had 5 waves over 2 years, and we were looking at things like discussion, frequency, and influence. There are many different metrics you can use in social network analysis, and it helps you see in real time how a network in a community is evolving. Starting with the 15 people, we end up with 400 to 500 people in the network within a community that the intervention strategies can be diffused to and who can help implement and sustain those interventions. So it's a much more efficient way to work community-wide. And last but not least, all this is to increase policy, practice, and environment and child health. And in this particular community, you can see through our policy, practice, and environmental score that between baseline and 24 months, we were actually able to increase that score through the stakeholder-driven community diffusion model that I just showed you. So I hope you'll visit us. This is our website, catalyzingcommunities.org. We're working across the country with communities with this deep process and always looking for new partners. I want to summarize what I talked about today and leave you with 10 key things to take away. Childhood obesity prevention must start early. As you saw from the obesity prevalence, it is lowest in 2 to 5-year-olds, but it becomes the highest in 12 to 19-year-olds. And we know that preventing obesity early in life is the most important thing we can do to change the trajectory for adults or prevent adult obesity. Multi-sector, multi-level, whole of community approaches are needed, and they seem to be right now the ones that may have the most efficient and sustained impact. Purposeful, sustainable, and evidence-based intervention packages can work. Coordinated connections between sectors and levels using system science methodologies is innovative and captures the complexity more than single or just in parallel interventions. Rigorous design and evaluation procedures are imperative. Reducing disparities requires equity-oriented strategies that reach high-risk communities and address the underlying societal structures and disadvantages. Emerging evidence does show us that COVID-19 appears to have increased obesity and related behaviors. Scaling what works requires more implementation science funding in the category of D&I or dissemination and implementation. Training future leaders mandates interdisciplinary education and experiential opportunities. The thinkers of the future will go beyond single siloed disciplines. And systems change is about shifting the conditions that are holding the problem in place. I want to acknowledge many of my collaborators across the globe that have been working on this with me. And thank you. Here's my email address. I look forward to the Q&A and hope to hear from many of you.
Hello, it's a pleasure to be here, to be speaking at this Pennington, Louisiana Department of Education symposium. I'm going to be talking about trends in food sources and diet quality among U.S. children. So, before we talk about those specific trends, I just really want to emphasize that poor nutrition is the leading cause of poor health in the United States. And actually, because of poor nutrition, more Americans are sick than are healthy. Half of adults in the United States have diabetes or prediabetes. More than half of cardiovascular disease. 3 in 4 adults are overweight or obese. And because of these diet-related diseases, as well as high cholesterol, only 12% of adults are metabolically healthy. So almost 90%, 9 out of 10 adults are actually sick. And that starts, if we really want to prevent this, that starts in childhood. We have to think about how to have healthier children. Now, there are tremendous economic costs to these diseases. Over 50 years, healthcare costs in our country have skyrocketed from 5% of government budgets to almost 30% of government budgets. Adjusted for inflation, healthcare spending by businesses has risen from $79 billion to $1.2 trillion for U.S. businesses. Today, more than $11,000 per man, woman, and child in the U.S. For a family of 4, we're spending $44,000 per year on just healthcare. That's more than the average family spends on housing and food, and more than many families actually make in the entire year. Now, this has been worsened and highlighted and made really, starkly obvious by COVID-19. COVID-19 is not just a respiratory virus, it's a vascular virus affecting our blood vessels and endothelial cells and causing clotting, and it's an inflammatory virus. And so COVID is, of course, a devastating virus, but it's much worse because of diet-related diseases. Diabetes, obesity, and hypertension in particular, which are all diseases of diseased endothelial cells and systemic inflammation. And so you have a virus that attacks the endothelial cells and causes overwhelming inflammation. Obviously, it's going to be much, much worse, and this explains why it's much, much worse in people who have underlying diseases where they're starting out with diseased blood vessels and excess inflammation. And so these diet-related diseases, diabetes, obesity, and hypertension, are the top risk factors for poor outcomes from COVID. And so really, I think we should be thinking about COVID-19 as a fast pandemic on top of a slow pandemic. The fast pandemic is the virus. The slow pandemic is the 30-year pandemic in this country of obesity and type 2 diabetes. And in fact, we estimated how many COVID-19 hospitalizations could have been potentially prevented because people wouldn't have been as sick if we didn't have the rates of obesity, diabetes, hypertension, and heart failure, cardiometabolic conditions. And we estimated 64% of hospitalizations could have been prevented, nearly 600,000 excess hospitalizations. Think about that. We could have had potentially a 1/3 rate of hospitalizations and then, of course, deaths than we've had to date if we had a metabolically healthier population. Now, the economic costs are just as dire. This is a report just out last month from the Rockefeller Foundation done by McKinsey Corporation. They looked at the external costs of food that aren't usually accounted for in our economy. On average, in a given year, we spend about $1 trillion directly buying food. And at the same time, while we're spending that $1 trillion, we're costing our economy another $2.1 trillion in lost economic value per year. Over $1 trillion, these are billions of dollars, these values, over $1 trillion in lost human health from poor nutrition, over $350 billion from poor use of the environment, $455 billion from loss of biodiversity from the ways we grow our food, $134 billion from lost livelihoods. And so we're spending $1 trillion a year on food, and it's in addition costing our economy $2.1 trillion. Those are numbers that can't be ignored. And so we really need to shift our entire priority for national policy, state policy, government, businesses, private sector, science to focus on nutrition security. This is the top cause of poor health, a huge issue for the environment, a huge issue for economy. We have to advance nutrition security. Now, some of you may not be as familiar with the term nutrition security because food security has been, really used widely for 25 years. Nutrition security is the idea that all people should have consistent access, availability, and affordability of foods and beverages that promote well-being and prevent, and if needed, treat disease. And this is intended to really emphasize healthy food, nutrition. Most policies and programs that have tried to address food security, improve food security, have actually focused on calories. And we need to move beyond calories alone and add the focus on nutrition. And Secretary Tom Vilsack, Secretary of the USDA, in his confirmation hearing, really highlighted how important nutrition security is as a goal, saying our nation suffers from nutrition security. We must do more to ensure access to the nutrition foods that can protect and promote health, not just empty calories or harmful calories, but nutritious calories. So what's going on in children? How are we doing? Well, unfortunately, not well. These are the trends, percentages of American children overall who are eating a poor quality diet, an intermediate quality diet, and an ideal quality diet, defined by the American Heart Association diet score, which is a validated diet score that predicts disease outcomes and mortality and mostly focuses on foods as well as some nutrients. And you can see there is some good over the last 20 years. The percentage of children who are consuming diets of poor diet quality has substantially reduced from 77% in 1999 to 56% in 2016. Of course, we expect, although we don't yet have data, that this has gotten worse again during the pandemic, but we don't have national data on that. But over this period, the percentage of kids with poor diet quality has improved, mostly because of improvements in kids with intermediate diet quality, which is almost doubled from 23% to 44%. And unfortunately, the number of kids with ideal diet quality, which really isn't that extreme, roughly meeting the dietary guidelines for a handful of foods and nutrients, is still, abysmally low. Less than 0.25% of kids actually meet ideal quality. So, dark clouds, but with silver linings. The silver lining is that the percentage of kids with poor diet quality has improved. The dark clouds, of course, are that still more than half of all kids in this country have poor diet quality, 56%, and less than 1% have ideal diet quality. Now, what are those improvements due to, and what are the residual problems due to? Well, let's look at fruits and vegetables. So, looking at total fruit intake, it's actually pretty flat, but the intake of whole fruits have gone up, and the intake of 100% fruit juices has gone down in this country over the last 20 years. That's a positive. That's a positive advance. Vegetables, some improvement, but it's still pretty low. And so the number one vegetable consumed in the United States is white potatoes, up there in blue, and then you have tomatoes and other vegetables. And really, the healthiest vegetables, red, orange vegetables, dark green vegetables, are extremely low, less than 0.1 servings per day on average for the American children, without a lot of improvement over these years. Although potato intake has gone down a little bit, which is a good thing given all the starch in white potatoes. Now, what about dairy? Well, milk intake is actually going down and being replaced with cheese. And although intake is low, so you can't see it, a significant increase in yogurt consumption. So overall dairy is fairly flat, but cheese intake is going up and yogurt intake is going up. That's positive. Cheese is a fermented food. Yogurt is fermented and has probiotics. And so cheese and yogurt seem to be metabolically better than milk for children. So this is a positive trend. Among meats, very little trend. If you look at unprocessed meats in orange, processed meats in blue, seafood intake down here, high or low seafood intake, pretty flat. And so you see the huge differences between meat intake and seafood intake. Very, very small amounts of seafood intake in kids. Poultry intake has gone up a little bit. Poultry is pretty neutral for health. It's neither really good or bad for us, so I don't know that has a major health impact, but it has gone up in children over this time period. Now, other improvements have been seen in whole grains. Whole grain intake has gone up. It's doubled, in fact, from a half serving per day to 1 serving per day. That's a pretty big improvement. overall in the United States, again, from a half serving to 1 serving per day for kids in the United States. We should definitely be happy with this improvement. But at the same time, kids are eating more than 6 servings of refined grains per day, and that hasn't budged at all. And so again, dark clouds here, but silver linings here. And maybe one of the brightest spots has been sugar-sweetened beverages, which is leading to a reduction in added sugar. Sugar-sweetened beverage consumption among kids in the United States has gone down by 50%, a huge, huge decrease from about 2 servings per day on average of sugar-sweetened beverages down to 1 serving per day on average. So this has been a big win, and this is what leads to this decline in overall added sugars. Added sugars from foods has not gone down very much. So if you put all this together, what do we see? We have some improvements in nutrition quality in kids. It's due to substantial declines in sugar-sweetened beverages, improvements in whole grains, small improvements in yogurt and cheese, improvements in whole fruit intake, but no real increase in vegetables, no reduction in refined grains, no real change in seafood intake. And so there's been improvements, but still a lot of work to do. Now, the key point, to make about these improvements is that they are inequitable. They are not the same by race, by parental education, or by family income. So this shows, similar findings, the proportion of U.S. children with a poor quality diet, not overall, but by the ratio of family income to poverty level. And so red is low income, yellow and blue is sort of intermediate income levels, and green is highest income families in the United States. And you can see that while all groups have improved, the proportion of kids with a poor quality diet have gone down in all income groups. There are pretty significant disparities that, if anything, are getting bigger. And so by the most recent national data that we published on, in low-income kids, still 65% have a poor quality diet compared to high-income kids, where 47% have a poor quality diet. Now, there's 2 take-home messages here. There's significant disparities where, low-income kids have significantly worse diets than high-income kids. And the second take-home message is that having a high income does not protect you from poor diet. And so it's not as though high-income children are having a great diet. Still, a full half of kids with adequate incomes in their families have poor quality diets. So again, some improvement, but a lot of work to do in terms of overall improvements and disparities. So if we're going to address this, we have to understand, well, where are the trends? Where are these foods coming from? And this is a paper we've just recently published. I think a really important paper to try to understand where are the foods coming from and what's the quality, nutritional quality of these different food sources. So this shows the percentage of daily calories that kids are consuming in this country from different food sources among children aged 5 to 18. And what you see is that there haven't been a lot of change over time. Generally, schools are contributing about 9% of calories year-round. That might seem low to people, but if you think about the fact that year-round, kids are in school half the time, 180 days, and also they don't have all of their food at school. They generally have less than half their calories at school, or when they're at school. That number makes a little bit more sense. And so overall, schools are about 9% of calories year-round, and restaurants are about 15-20% of calories. Other sources, which includes like entertainment venues, food trucks, gifts from others, that actually has gone up, and so that's an increasing source of calories. And by far, the biggest source of calories for U.S. kids is grocery stores. So the food that their parents are buying for them in the grocery store, or that they're buying themselves. And so we focused a lot appropriately on schools for kids. We've talked about fast food restaurants in this country and policies around that. We've talked very, very little about the food in the grocery stores, and that's where most of the food is coming from. And so if we really want to improve nutrition in kids, we do need to think about all these sources, but grocery stores are the absolute top priority. So what are the nutritional quality of foods from these different sources? Now, importantly, what this analysis shows is not what is offered in these venues, but what is actually purchased and eaten in these venues. And so this is really what kids are eating from these venues, not just what's offered. And again, we're showing the percent of food with poor nutritional quality. So restaurants are the worst. Over 80% of food in restaurants that kids are consuming today are poor nutritional quality. It's a little bit better for full service restaurants. It's a little bit worse for fast food restaurants, but it's actually not that great for restaurants overall. And so really, restaurants are not a healthy place for kids to be eating, whether they're full, on average, whether they're fast food or full service. Other sources in grocery stores, about half of all the food from grocery stores and other sources is of poor nutritional quality. So also, a huge problem and a huge challenge. Now look at schools compared to everything I've shown you, where we look at restaurants, grocery stores, other sources where the nutritional quality is, pretty much flat. Look what's happened with schools between 2003 and 2018. If you look between 2003 and 2010, about 55 to 60% of food consumed in schools is of poor nutritional quality. So you would not want to get a school meal. If you were a parent sending your kid to school, you would not want them to go to school meal because the majority of that food would have been of poor nutritional quality. And after 2010, a steep decline in food of poor nutritional quality, so that by 2018, the latest a year with national data, only 25% of school food now is food of poor nutritional quality. And in fact, schools are actually the healthiest place that kids are eating on average in the United States, whether it's restaurants, grocery stores, or other sources. They're getting their healthiest food from school. Why did this happen? Why this incredible, huge improvement? Well, there's one very clear explanation. In 2010, the passage of the Healthy, Hunger-Free Kids Act. This was legislation by Congress to improve the nutritional standard of school meals, more whole grains, more fruits and vegetables, less added sugar, less removal of soda from schools. And when we look at the dietary changes that lead to these improvements, we see exactly those improvements: more whole grains, more fruits and vegetables, less added sugar, less sugar-sweetened beverages. And so what I think is really important here is to emphasize the power of policy to improve nutrition for U.S. children. With all the work and efforts we've been doing to talk to restaurants, to talk to food manufacturers, to educate people, the dietary guidelines, everything we've been doing, there have been very, very slight improvements in nutrition quality in restaurants, very slight improvements in nutritional quality in grocery stores, and actually a pretty significant worsening of nutritional quality from other sources like entertainment venues and food trucks. So pretty small changes, and a single policy, a single law passed by Congress in 2010, dramatic improvements in nutrition for millions and millions of American children. So it's the power of policy to improve nutrition in this country. And I think, as I showed you before, the equity issues continue to be very important. And so when you're looking at restaurants, I showed you there were some very slight improvements. If you look in both children, and here I'm also showing you adults for comparison, if you look at the proportion with poor diet quality, which is in blue, so just focus on the blue, by income, family income, low-income kids and low-income adults, almost no improvement in nutritional quality of food from restaurants. Middle income, a little bit of improvement, and high income, although it's still modest, are the best at the end. And so there's disparities here by family income in the nutritional quality of food consumed from restaurants. If you look by grocery stores, it's even more obvious. And so again, focus on the blue, the proportion of food of poor diet quality. This is showing you children and adults, low income, middle income, and high income in the United States. Very little improvement in children, a little bit of improvement in adults and low income adults. Middle income, very little improvement in children, although a little bit of improvement, and a little bit of improvement in adults. And again, nutritional quality of food from grocery stores, pretty big improvements in high income Americans. So high income Americans are really the ones in restaurants and grocery stores that are able to go out through education, income, access, opportunity cost, and get healthier food in restaurants and grocery stores. Now I want to contrast that with what's happened in schools. And so now, instead of showing you children and adults, I'm showing you all children by income and by race. And so this graph is children, white, non-Hispanic, Black, and Hispanic children. And this graph is low income, middle income, and high income for families, for children. And this is showing you schools. So in contrast to the disparities in nutritional improvements in grocery stores and restaurants, look at the nutritional improvement in schools for children, regardless of race or income. And we also looked at education, and it was very similar. Again, focus on the blue. You see across different races, across different family incomes, very, very similar improvements in nutrition quality in schools. No significant differences in improvements in nutritional quality. So again, a single policy improved nutrition for millions and millions of American children and did it equitably. It shows you the huge power of smart policy versus trying one by one to educate and cajole food companies, restaurants, and the public to try to eat healthier. What about junk food and ultra-processed food? I showed you kind of fruits and vegetables, but what about these other categories? And so we've also looked at these categories. Junk food, we focused not on sugar-sweetened beverages, but on foods, on savory and sweet snacks, bakery products, ready-to-eat meals, and so on. And ultra-processed food is a much larger category. That's really any manufactured food that has multiple ingredients, multiple additives, and is really not minimally processed. We've looked at also at these trends. This is the percentage of energy overall among US children from junk food in the United States. It's really not improved very much. And again, I'm excluding soda. Soda's gone down by half. But if you exclude soda and you actually look at food, snack bars, candy, savory snacks, crackers, desserts, and sweet bakery products, pretty much constant, about 18% of calories from 17 to 18% of calories in kids in the United States is from junk food. 1 in 5 calories in kids is from junk food. This is really, really, incredible and problematic. And if you look at the sources, where is this junk food coming from? 73% of it is coming from grocery stores. Only 8% of it is coming from restaurants. Only 5% of it is coming from schools. And 13% of it is coming from other sources. So again, the grocery store, where parents are making decisions and older kids are making decisions and food manufacturers are making decisions, are the big drivers of junk food consumption among kids in the United States. And what's interesting for junk food, and you'll see similar things for ultra-processed food, the same disparities we saw for overall food quality in terms of food ingredients and nutrients isn't seen for junk food. And so here we're looking by race and by parental education at the proportion of energy from junk food in the United States. And here, non-Hispanic whites are, at high up here in the percentage of energy from junk food, followed by non-Hispanic blacks, and Mexican American children actually have less junk food on average than non-Hispanic whites and children. And if you look by education, this is looking at parental education, kids whose parents have some college or more, the most education are having more junk food than kids whose parents have a high school graduate education or less than high school. And we look by income, and these graphs were superimposed. So for junk food, interestingly, white children and more educated families are eating more junk food, or certainly not less than lower educated and minority children. So junk food is not, the disparities are reversed here, and I think it's a very important and interesting finding. And if we look at ultra-processed food, which again is this larger category of minimally processed food, this has gone up, unfortunately, in children in the United States, from about 61% of energy to 67% of energy. The blue is all other food. And so here, as a percentage of energy, ultra-processed foods have gone up to 2/3 of all calories among US children. And what does that due to? If you look at all the different types of ultra-processed food, sugar-sweetened beverages have gone down, and so that's a positive. Yellow is 1999, blue is 2018, and so you see in terms of percentage of energy intake, kids used to be having 11% of calories from sugar-sweetened beverages. It's down to 5% of calories. Big improvements. That's an improvement, but that's been offset by a huge increase in ready-to-heat and eat mixed dishes, pizza, other ready-to-eat dishes, sandwiches, hamburgers, from about 3% of calories among kids in 1999 to 12% of calories, a huge increase. So parents are stressed. They're getting ready-to-eat and ready-to-eat pre-prepared dishes, and that's really harming kids' diets. And also an increase in sweet snacks, particularly sweet bakery products, have gone up in this country. And as we saw for junk food, interestingly, when you look at the percentage of energy from ultra-processed foods and the trends by race or by education or income, you don't see the same disparities you see for fruits and vegetables and other things. Here, non-Hispanic whites and non-Hispanic blacks are consuming more ultra-processed food than Mexican American children, probably because still it's more true in Hispanic and Mexican American children. They tend to have families that are cooking at home more, buying at the grocery store more, and preparing their foods and are eating less processed foods. And if you look again at family income or parental education, just overlap. There's really no difference at all. And so junk food and ultra-processed food is not solely a problem for minority communities or for low-income communities or less educated parents. This is a universal problem for all of our children in the country. So in summary, since 1999, overall diet quality among kids, if you look at food ingredients and nutrients, has slowly improved. Poor diet has gone down from 77% of kids to 56% of kids, and that's due to increased fruits, whole grains, yogurt, and lower SSBs, but still poor diet in more than half of kids, and there's major disparities in overall diet quality by race, income, and education. If we look by food source, there's very little improvement in food from restaurants, modest improvement from grocery stores, and worsening from other sources, with significant disparities in all of those things. In contrast, there's been dramatic improvements in the nutritional quality of food from schools, to where now food from schools is the healthiest food on average that kids are eating in the United States, and it's equitable, and all of that is after a single policy change, the Healthy Hunger Free Kids Act. Junk food is nearly 1 in 5 calories among US children, and it's not going down. And ultra-processed foods are increasing among US children, now 2 in 3 calories among US children. Grocery stores are the major source. And for junk food and ultra-processed food, intakes are highest among whites and non-Hispanic Blacks, lowest in Hispanics, and there's little differences by family income or parental education. And so if we want to fix this, which obviously we have to, both for adults and children, I really want to emphasize, the need for policy change, for systematic changes in communities, at the state level, and especially at the national level. Science and innovation, food as medicine and healthcare, economic incentives, utilizing schools and work sites, utilizing the power of the FDA for standards and labeling. And so it's been very nice to speak with you, and I hope you enjoyed this presentation.
Good afternoon. Thanks so much for being here. I'm excited to talk about some of the work that myself and colleagues have been doing related to the impact of school breaks on children's BMI and related health behaviors. My name is Glenn Weaver. I'm an associate professor at the University of South Carolina in the Arnold School of Public Health. Before we get going, I did want to just acknowledge that I've received some funding from the National Institutes of Health and some internal funding at the University of South Carolina from the Arnold Childhood Obesity Initiative. I did want to also acknowledge my colleagues and the staff and students that make up our research group. Without them, none of this work would be possible, and I wouldn't be able to present here to you today. As many of you are well aware, we're in the midst of the childhood obesity epidemic. It's why you logged on to this webinar today, so I'm not going to belabor this point. What I do hope that I bring today is a little bit of a different perspective, where we talk about maybe how school breaks might be impacting children's risk for childhood obesity and their engagement in unhealthy behaviors. But in order to do that, I think we have to flip that on its head a little bit and start with, well, how have schools been situated in terms of preventing and treating childhood obesity and their obesogenic behaviors? The idea that schools can have an impact on children's obesity and obesogenic behaviors is not a new idea. In fact, the President's Council on Sports and Fitness and Nutrition was founded in the 1950s by President Eisenhower. More recent efforts like Let's Move Active Schools and the Alliance for a Healthier Generation have also focused on schools to promote healthy eating, physical activity, and healthy behaviors in order to treat and prevent childhood obesity. So the common message that is communicated to schools is that they're not doing enough to address children's health. They need to be doing more, and that's implicit in these programs that have targeted schools to increase the health of our youth. This message also manifests itself in national reports produced by large organizations. For instance, in this case, this is the Physical Activity Report Card for Children and Youth. And this report card rates schools as a D-, again, indicating that schools should be doing more to promote children's physical activity. Another example of this is the Educating the Student Body report that was released several years ago from the Institute of Medicine, now the National Academy of Medicine. And the subtitle in this is Taking Physical Activity and Physical Education to School. Again, in order to take physical activity to school, it would have to not be there in the first place. So this is the message that schools are not doing enough. And not to belabor this point, but this message also shows up in the research literature. For instance, a recent systematic review of obesity disparities research conducted from 2011 to 2016 identified that schools were the primary target of these interventions in 70% of the studies identified. So it's pretty clear that the common message is that schools need to do more to address childhood obesity. However, I'm not so sure that that's the case or that the data backs up that message. In fact, I think the evidence actually indicates the opposite, and that schools may be the most healthy environment in which children find themselves. And so I'd like to spend the rest of my talk presenting you some evidence that shows that maybe it's school breaks that are undermining children's health, and maybe schools are doing quite a bit to address the childhood obesity epidemic. One of the seminal studies that supports my perspective was conducted by Dr. Paul von Hippel out of the University of Texas at Austin. He used a nationally representative data set of about 18,000 children from kindergarten through first grade to look at trajectories and body mass index during the school year and during the summer. What this figure shows is body mass index on the y-axis and months along the x-axis. And this shows trajectories during the first grade and during kindergarten. What we see is that BMI, or body mass index, is mostly flat during the school year, remaining relatively the same. However, when you look at the BMI change of these children during the summer, BMI gain accelerates, indicating that it's the summer, not the school year, that may be contributing to the obesity epidemic. In a subsequent study conducted in Texas in a large cohort of children from kindergarten through fifth grade, we see much the same trend if we look at the percentage of children who are overweight or obese. Here we have percent of children overweight or obese on the y-axis, and on the x-axis we have each grade. In the yellow represents the summer, and the white represents each school year. And what we see is during the school year that the percentage of children who are overweight or obese is largely flatlined. And in some school years, like second or fourth grade, we actually have a reduction in the percentage of children who are overweight or obese, but each summer, very consistently, there is a dramatic increase in the percentage of children who are overweight or obese. And so when we start to talk about this, a common reaction that I've gotten, and a reaction to one of the papers that I recently published on Twitter, was that, wow, times have changed. This didn't used to be the case. Children used to be more active during summer vacation, or I can't believe children are gaining BMI over the summer. That's not how it used to be. And I would counter that message as well. For instance, if we're talking about the seminal paper from Dr. von Hippel, this data was collected in 1998, making it at least 20 years old. In fact, one of the earliest studies showing accelerated summer BMI gain is a large-scale intervention study that collected data over 2 years in the early 1990s, indicating that accelerated summer BMI gain is not a new trend. It's something that's been around for a long time. These are just a few studies that illustrate an emerging body of literature that's showing that trend of accelerated summer BMI gain, which leads you to the logical question, well, why is this happening? Why are children gaining more BMI during the summer than during the school year? And so I'd like to spend the next couple of minutes talking about at least one theoretical perspective on why this might be the case. So my research group has done some work in this area trying to understand why children might be experiencing accelerated summer BMI gain, and we refer to this perspective as the structured days hypothesis. The structured days hypothesis posits that on days when children engage in relatively more structured programming that's characterized by adult supervised, scheduled, segmented programming, that they will engage in more healthy behaviors when compared to days that they engage in less structured programming. And the figure in front of you represents a school day on the top versus a non-school day on the bottom. On the top, the child's sleep patterns are regulated by school start and end times. They are served meals and snacks that are calorically capped and meet nutrition guidelines. Screen time is regulated and restricted. And they've provided physical activity opportunities through PE, recess, classroom activity breaks, transitions between lessons. When compared to a non-school day where sleep is not regulated, children may or may not have access to physical activity opportunities, meals and snacks that are calorically capped and meet nutrition guidelines, and screen time may be at children's own leisure. Thus, it's pretty intuitive that a school day may be more healthy than a non-school day. I did also want to briefly mention that the reason we're talking about sleep in relation to the structured days hypothesis is that studies have shown that children who sleep for shorter amounts of time, have inconsistent bed and wake times, and go to bed later and wake later are at elevated risk for overweight or obesity. As part of the study that presented the structured days hypothesis, we did a systematic review looking at children's health behaviors on school days when compared to non-school days, largely weekend days. And what we found is that pretty consistently children's health behaviors were more healthy on school days when compared to largely weekend days. For instance, if we're talking about moderate to vigorous physical activity or physical activity that makes children breathe heavily, sweat, and elevates their heart rate, 85% of the studies showed that children engage in more moderate to vigorous physical activity on the school day than on weekend days. Similarly, children engaged in less sedentary behaviors, so seated activities, typically non-movement activities, on days that they attended school, and more sedentary behaviors on non-school days. So that's one review of the literature that was conducted by our team of data showing children's health behaviors on school days versus non-school days. However, many of the studies included in that review were not specifically designed to answer questions related to the structured days hypothesis. So I'd like to walk you through some studies that were designed to do that. However, these studies are not experimental manipulations, and thus the data from these studies should be characterized as suggestive and not definitive. And so one of the first studies I wanted to look at was one of the studies that I conducted. Was funded by the National Institutes of Health. And in this study, we looked at the impact of year-round schools on children's BMI and fitness. So I think one of the first things that we need to do to understand this study is to understand the difference between year-round and traditional schools. I think year-round is a bit of a misnomer. I think balanced school calendar might be a better term for year-round schools. And in these balanced or year-round school calendars, instead of attending school in a typical really short 9-month period, what these balanced school calendars, year-round school calendars try and do is spread those days out across this 365-day calendar year. A typical schedule for year-round school or balanced school is that children will attend school for 45 days, take a 15-day school day break, so 3 weeks, attend school for 45 days, take another 15-day or 3-week break from school. So it's a 9 weeks on, 3 weeks off calendar, and it's spread throughout the year. And so in this study, we had 1 year-round school or balanced calendar school, and we had 2 match-paired traditional schools that were following a traditional school calendar, but were matched on school outcomes, race, ethnicity, age, and grades served to be similar to this year-round school. And so what we did is we measured children's height and weight at the beginning and end of each traditional school year, so in August and May of each year. We measured both the traditional and the year-round school children's heights and weights, and we translated that into age and sex-specific BMI scores. And here is the pattern of BMI gain for children who are attending the traditional school. And so what we see is that kind of classic pattern of more of a flat line during the school year, here represented in the gray, and an acceleration in that BMI during the summer, here represented in the white. Now, if we overlay our year-round school children's age and sex-adjusted BMI scores on top of the traditional trajectories, we see something very different. These are represented by the dashed lines and the white dots. We see that children in the year-round school actually experienced accelerations in BMI during the school year and decreases in BMI during the summer. And what we hypothesize here is that because we're distributing this structure throughout the calendar year, children in the year-round school are experiencing relatively fewer structured days during the school calendar year because they're taking those 3-week breaks every couple of months. And children in the summer and the year-round school calendars are experiencing relatively more structure than the children in the traditional school because they're getting some school days during the summer when compared to our traditional school children. So again, this is suggestive. We need more measures and more time points to really understand what exactly is going on here, but it's very interesting and suggestive. Additionally, in this study, we provided children with a Fitbit device that allowed us to track sleep and physical activity on school days and school breaks. For the traditional school children, we got a 1-week break in the spring, and for the year-round school children, we got a 3-week break in the spring. And so what this allowed us to do is to look at physical activity not only on school days and non-school days, but during school hours when children attended school and on school breaks. So physical activity, this is light physical activity in this figure. Physical activity on school days is represented by the black bar, and physical activity on break days is represented by the dashed bar. And what we see is, number one, that during school hours, children accumulate more light physical activity. And then equally as important is during non-school hours on both school and break days, physical activity seems to be relatively similar, indicating that the additional light physical activity that children are accumulating happens during the school day and indeed in school when school is in session. And this pattern also held for moderate to vigorous physical activity, or physical activity that gets children up and moving, makes them sweat and elevates their heart rate. Again, more physical activity on school days during school hours compared to non-school days, and after school hours looks pretty similar in terms of the amount of moderate to vigorous physical activity. For sleep in this study, we were able to look at duration and sleep timing in the school year and during the summer on about 285 children. And what we found is that in time one, when all children were still attending school, sleep timing when children went to bed and woke was pretty consistent. And sleep duration in turn was pretty consistent. However, during time two, when the year-round school children were still in school and the traditional school children had gone on summer break, we saw the traditional school children had later sleep times and wake times while maintaining about the same sleep duration. So it appears as if removing the school day impacts children's sleep timing, but not necessarily sleep duration. This is a critical finding, as a recent study that came out of one of our colleagues' labs, Dr. Jenny Marino, showed that later sleep timing or greater shifts in sleep timing in the summer also predicted greater ZBMI gain during the summer. In addition to looking at children's BMI trajectories and behavioral data in the school year versus the summer, we've also done some work looking at children who attend structured summer programming like summer day camps in the summer as well versus children who do not attend summer day camps. The logic being that if the structured days hypothesis holds, children who attend summer programming should not see accelerated summer BMI gain and also engage in healthier behaviors. One instance of that is a small single group study of about 20 children where we measured children's BMI prior to and following a 6-week summer camp. And we also had children wear activity monitors on their wrists for 2 weeks while they were attending the summer camp. So here are the physical activity outcomes. This is moderate to vigorous physical activity. The dotted line represents children's MVPA on days that they attended programming. The dashed and solid line represents days that children did not attend for different reasons. And then this is across the day. So we have from midnight to 11 p.m. the minutes of MVPA that children were accumulating. And what we see is that, again, during the hours of the program, on days that children attend the program, they're engaging in higher levels of moderate to vigorous physical activity. This adds up to about 45 minutes of moderate to vigorous physical activity on a day they attended versus 25 or 24 minutes on days that they did not attend. And then looking at the BMI data for these children that attended summer programming, again, only 20 children in a single group study, so not the strongest evidence, but we did not see any increases in BMI, which is contrary to what you would expect if you're thinking about accelerated summer BMI gain. Another study was conducted in Texas in adolescent boys, about 150 of them. And this study compared boys who attended a summer school program versus boys who did not attend a summer school program and measured a variety of fitness metrics prior to and following summer vacation. These metrics included percent body fat. And so when we look at changes in percent body fat for boys who attended summer school, very minimal increase, about 0.2%. Compared to boys who did not attend, we had about a 1.4% increase in percent body fat. And so, again, consistent with the structured days hypothesis, where children who attend structured summer programming are not gaining body composition or BMI. In addition to this suggestive data, there's also been some recent experiments that have randomly assigned children to attend a summer program or not attend a summer program, and then looked at BMI outcomes and behavioral outcomes. I'm aware of 2 of these studies, one conducted in a colleague's lab and one conducted in our lab. The first study that I'm aware of was conducted by Dr. Whitney Evans. In this study, 100 children were randomized to either 8 weeks of summer day camp or summer as usual, so no summer day camp. These children had their height and weight measured at the beginning and end of summer, and that was transformed into age and sex-specific BMI Z-scores. And the findings of this study are really interesting and largely consistent with the structured days hypothesis. So on the left, we see children's change in BMI Z-score for those children that attended camp and those children that did not attend camp. And what we see is that children that attended camp actually had a reduction in BMI Z-score during the summer, and children who did not attend camp had an increase in BMI Z-score. Additionally, Dr. Evans looked at 3 distinct buckets of children: children that attended 0 to 12 days of camp, children that attended 12 to 26 days, and children that attended greater than 26 days. And she also saw that there was a stair-stepping pattern of reduction, so that children who attended more camp had greater reductions in BMI Z-scores. The second study that I'm aware of was conducted by our lab, and this study, 180 children were randomized to either receive a health and academic focused summer program, no program, and a third group was selected by a school district to attend a summer learning focused only program. Children's behaviors were measured during the program using Fitbits, and height and weights were measured at the beginning and the end of the school year. So for our BMI data, we found much the same pattern as Dr. Evans found, where children who attended more experienced no gain in BMI Z-score, and children who attended less of the program experienced more gain in BMI. Our behavioral data was largely consistent with the structured days hypothesis as well. For instance, what we saw is on days that children attended any structured programming, they engaged in less sedentary time and more moderate to vigorous physical activity. That is, activity that gets children up, moving, makes them sweat, and elevates their heart rate. I did also want to very briefly mention that accelerated summer weight gain is maybe affecting children from low-income families to a greater degree than children from higher-income families. And based on the structured days hypothesis, we believe that that is because these low-income children don't have access to structured summer programming. So looking at the evidence, what conclusions can we draw about the impact of summer vacation and breaks from school on children's health behaviors and body composition? The evidence is pretty clear that children's BMI gain accelerates during vacation from school. This may be because health behaviors deteriorate during breaks from school and might be explained by the structured days hypothesis. However, more work is needed because most of these studies had small sample sizes and there's limited experimental data. In the meantime, though, I do feel confident saying that providing children with access to structured programming is a worthwhile thing. This is because it will most likely impact children's health behaviors, and there's documented evidence that it will impact children's academics and children's pro-social behaviors. With that, I wanted to say thank you for having me today, and I look forward to answering your questions.
All right, I think that's all of our speakers. I want to thank everyone for such intimate and detailed presentations. I learned a lot, and I hope you guys did as well. We do have a couple of questions in the chat box, and I actually have one would like to get in, but we'll start off with one from Catherine Champagne to Dr. Weaver. Is the stability of the weight during the school year more about physical activity increase or improved nutrient intake?
Yeah, that's a really good question. And I would say that the reason that I leaned heavily on sleep and physical activity is because the data is better there in terms of physical activity and sleep. There's been more studies that have looked at that, and it seems to be pretty consistent with the structured days hypothesis. The studies that have looked at diet in school year and then on summer vacation have not used the strongest measures. So we've used like food frequency questionnaires and maybe some weaker measures. And so we don't typically tend to see a difference, but I'm not sure if that's because of the measures that we're using or because there's actually no difference. The other thing I'll say too is most of the studies that have looked at diet have used parent proxy reports of diet for children during the school year in the summer. And that's really hard for a parent to report on if they're not with their child during the school year, but then maybe we are with our child during the summer. So it's really tough to measure diet and to look at that during the summer and the school year. And I have an intuition that diet does get better during the school year, but I'm not sure that the data necessarily supports that currently.
It seems logical. I'm sorry, Dr. Connor, let's go for it.
It's okay. Can I weigh in?
Yes,
Yeah.
please.
Yeah, I totally agree. We published something a few years ago, and you're right, Glenn. We didn't use the best dietary intake tool, but it did really suggest what you're saying, which is that unstructured eating during the summer included a lot more ultra-processed foods and just a lot of erratic timing and calories. And I would just add what Dari showed, which is, the improvement in school food that's occurred, wouldn't be part of the summer diet. So those calories have to be coming from somewhere in the summer, and it's presumably restaurant and retail, or that other category that he mentioned includes, movie theaters and things like that, where you would get more of that in the summer, which is, replacing maybe the 9 or 10% of calories from school food, which are the best calories. So I think just together that definitely suggests that it's a combination of the two, but I couldn't agree with you more. The tools in the summer work that I've looked at, it's hard to collect those data. You need good, multi-day, 24-hour recalls, hard to get, especially when, kids over the age of 6 aren't with their parents that much.
And there is data out there, and it's just mixed right now. So there's some studies that show that actually diet gets better in the summer. There's some studies that show kids just eat more of everything in the summer, both healthy and unhealthy food. So that could be leading to it. I do want to emphasize that, if we're thinking about energy balance, nutrition and physical activity and sleep as a new risk factor are all important. So I don't know, saying one is causing this. It's a constellation of factors, and it's individual to people as well. So it's not that there's one size fits all here either, I would say.
Guys, I might be a little off base, but this is, I do some team doctrine here, and you do see a little more structure in the school system, but sometimes that structure is not correct. And I'll give you a quick example. Last weekend during the high school games, kids were cramping up. They were just drinking loads of pickle juice. You're talking about an African-American population with a lot of hypertension. And so I'm looking at the amounts of sodium that these guys are taking. So I spoke to the coach about just hydration prior to the game, not the day of the game, but the Monday before the Friday game. So there is structure, and I think I would have to agree with you, Dr. Weaver, that I'm sure it plays a role. But sometimes that structure within the school system are normal. So we got to start with the coaches, the teachers, and make sure they're educated and know how to properly provide nutrition for our athletes and students. Dr. Economos, I have a question for you. In your multi-component interventions, how do you tease out the effects of the different components? Example, BMI changes may be due to effects of 2 to 3 primary components, whereas 7 of the components may have had no effect. So again, how do you tease out the effects of the different components? You're on mute, Doc. I think you're still on mute.
Sorry, great question. The modeling we're doing now is enabling us to get a better handle on that. Most of the previous work that's been done hasn't been able to separate the effects of the different exposures. Okay. But I will say it's kind of the point that it's very hard to change biology with just one single intervention. And we do all this laboratory-based work, really getting a handle on quantifying diet and physical activity in a variety of settings in a variety of ways so that we can see under controlled circumstances whether there's an impact. But when you translate that to the real world, the exposure or the amount of the intervention is really going to vary. And I think the point is it does take a package or a portfolio. We can't expect one single intervention in the real world to actually cause the kind of shift that we want to see. What we do know is from a lot of the studies that I've done, how behaviors have changed. So I showed in the Shape Up Somerville data, for example, there was a reduction in screen time. There was an increase in physical activity. So, you know, you put those behaviors together and assuming they have the impact. But I think the modeling we're doing now in the current studies will enable us to get a better handle on that. But again, I just want to emphasize when you do these community trials, I think all the recommendations that the three of us showed all need to be implemented. You know, we can't rely on just one thing. It will be a combination.
Great, thank you. Dr. Mozafarian, I know you don't have video, but I'd like you to chime in. I see you made a couple comments. I'd actually rather than read them, have you speak on that for us, if you could, please. Hey, Doc, you're on mute, I think. Dr. Mozafarian, I think there you go. All right.
Nice to see you. No, I didn't make any question comments. I was just well, happy to join the panel and just saying hello.
Oh, great. Well, I think this might be for you then. Let me see. Very encouraging. Okay, Dr. Mozafarian, very encouraging changes in sugar sweetened beverages overall, which is a big win for public health. Oh, sugar sweetened beverages include fruit juice, etc., or just artificially sweetened. Do you see a difference in trends? So I guess they're asking more about the impact of sugar sweetened beverages, juices, etc. Do you see a difference in the trends?
Yes, that's a great question. So sugar sweetened beverages have gone down 50% in the United States in a very short amount of time. That does include sugar sweetened fruit drinks, you know, like Sunny Delight or other things. It does not include 100% fruit juice. 100% fruit juice has actually gone up a little bit, not down. I think, and the American Association of Pediatrics and others think that the health effects are not the same. And so there probably are some benefits to 100% fruit juice from fiber, phenolic, some other things. At the same time, you don't want a child or an adult to be drinking 6 glasses a day. Right. So, you know, up to one sort of age appropriate portion size is what per day is what's recommended of fruit juice. But on average, fruit juice has gone up a little bit while sugar sweetened beverages have gone down. The trends in sugar sweetened beverages, though, hide, you know, heterogeneity in that category as well. Soda's gone way down, but energy drinks have gone up. And so, you know, the Red Bulls and all these other kind of energy drinks are going up in kids. So that's a really bad sign as well. And then lastly, you know, overall junk food has not gone down at all outside sugar sweetened beverages. And so that's a missed opportunity. We've gotten the message to families and parents and kids about soda largely, but not about other sources of you know, junk calories.
I'd like to reach out to anyone on the panel to address this question. And this came from a text message to someone who couldn't communicate through the site. Gaming and nutrition in schools. You know, gaming is huge right now. A lot of these kids spend hours at night playing these games. They're up late at night. Again, and I think the question, anyone can take this question. What are your thoughts on gaming? How these young people are affected by gaming? They're up late at night. Cortisol levels are high. They're drinking lots of stubby, lots of junk food. Can you guys just elaborate a little bit on that?
Glenn, do you want to start? Or
yeah, I can start.
We're shaking his head over there. I think he's
yeah. So I think yeah, gaming is a real issue, and I think screen use in general is a real issue. But gaming, especially because of the addictive nature of it and the way that these games are designed to hook people in and continue for them to play for long times. Especially at night when we're delaying sleep, and studies have shown that you know, late to bed, late to rise is a risk factor for overweight or obesity, independent of duration and independent of shifts in timing. So yeah, gaming is a huge issue. And then pile onto that, eating while we're doing that late at night when maybe we shouldn't be eating. So yes, absolutely, it's a huge issue.
Dr. Connell, yep.
well, I was just going to comment. I mean, the original work on screen time before there was a lot of gaming really identified what Glenn said, in addition to displacement of any kind of physical activity, and then the advertising component, which I think is variable with gaming. I mean, there's sponsorship, there is advertising, there's suggestive, you know, product. placement and things like that. So that advertising was a big part of the relationship between screen time and weight in children.
Yeah, I would just add, agreeing with both of those comments, that people think about gaming and screen time in terms of physical inactivity and sedentary time, but the links to diet are pretty strong. And so both, especially television watching, but also the advertising in games and television. So we should think of those things as risk factors for poor eating, because of loss of sleep, because of advertising, because of eating, less mindfully. And that may be even a bigger impact than the physical inactivity. And then, this is such a concern that the biggest nation on the planet, China, has just announced that they're going to actually mandate limited game time for all kids in China. To I think 3 hours per week, if I remember correctly. Pretty severe, which you can do in a totalitarian country, but it just shows you the Chinese government recognizing that this is really detrimental to the development of their youth.
Dr. Mozaffarian, another question for you. So we get nutrient benefit from 100% fruit juice. Why do you think the American Academy of Pediatrics suggested it should not be consumed, or should it actually not be consumed in large quantities? It seems that it's better than a sugar sweetened soda.
Yeah. Well, so I think this gets to relative benefits of whole fruits versus juice versus other things. And so, ideally, you'd rather eat the whole fruit because you don't want to pack in 8 ounces, the equivalent of 7, the calories of 7 oranges that you might eat more slowly and eat with fiber and might fill you up, or cranberries or other things. So I think ideally we'd like to eat whole fruit, and that would be better. And if everybody was eating enough whole fruit, then maybe we'd recommend no juice. But because Americans are so far below the recommended amount of fruit intake, getting some of that fruit through 100% fruit juice, some of the nutrients through 100% fruit juice is reasonable. On the other hand, why limit it then, right? Why not just say, okay, get your 3 to 5 servings all in fruit juice? There's not perfect evidence, but I think pretty compelling evidence that liquid calories are not treated the same by the body and by the mind and by the microbiome as solid calories. They're digested more quickly, lead to insulin spikes, don't cause as much satiety. And there are juices, apple juice is one in particular, that don't have a ton of nutrients compared to some other juices, and kids can drink a lot of really quickly. And so while the evidence isn't robust, there's not actually great evidence that kids drinking lots of juice leads to obesity. All of the kind of first principles suggest that it would, and first principles suggest we don't want to encourage that. So I think the American Association of Pediatrics recommendations, which I agree with, are a good happy medium based on imperfect but suggestive science that we want to get some fruit, you want to get hopefully whole fruit, but while we're not doing it, juice is okay, but not too much. That's kind of weaving all of these intricacies to get to a sweet spot, I think.
And a second to that, Doc, what about juice with high pulp is a better option, at least for orange juice, as opposed to pulp fruit?
Well, that's it. Again, it's one of those incredibly important questions that, this is why we need a National Institute of Nutrition at NIH to be able to fund and test these studies. I don't know of any really meaningful study that's tested the health impacts. Certainly not the long-term health impacts of juice with pulp without. If anything, there might have been just a single meal comparison. So shouldn't we know the answer to that question? So I don't think we know the answer to that question. But first principles, if there's more fiber in a juice, it's probably a little bit better for you than less fiber.
Right.
Yeah.
Dr. Weaver, Dr. Economos, any comments on that, or you guys think Doc wrapped that one up pretty nicely? Yes, definitely. How do you standardize school lunches for the country? Is it possible? Should it be done? Open-ended.
Yeah, there's been a lot of efforts to do that with the, guidelines that continue to be updated as science emerges. You do see variability on the ground for anyone who's gone into a school recently, but there are national guidelines and they are based on the best science available. I think part of what, continues to be problematic are some of the additional foods that make their way in. Even though competitive foods aren't supposed to be allowed for young kids, there's still a decent amount of that does come in. But I think just again to reiterate, as Dari showed, there's been huge improvements in school food over the past decade. And it does represent, for kids from lower income or disadvantaged communities, it does represent more than, 9% of calories, but it's still not the major source of calories in children's lives. And, you can't standardize the retail environment to control what's coming into the home, but that's where we need to make a lot more progress right now. That's where a lot of the additional ultra processed, high calorie foods are coming into children's lives. So I think, sure, we can still do better with school, but we've come a long way, and it's probably, for a lot of reasons, as Glenn said as well, one of the best environments that children are in.
Another text message, they're comparing, I guess, the vaccination being mandatory in certain settings or vaccinations and masking in certain scenarios. Why is it not mandatory that each school system have the same dietary guidelines? And I guess it speaks to what you just said, but it's a little redundant in the sense of what I just asked you, but is that possible or should that be done?
Oh, I mean, there are USDA guidelines that for reimbursement of a school meal, you have to follow those guidelines. The industry piece of it, which I know Dari can speak to as well, it's based on nutrients, and there is a way to create more processed products that make their way into schools, which if any of us looked at, we'd say probably not ideal, but it meets the nutrient requirements. So there's room for improvement there, but there are USDA standardized nutrition requirements that if you're getting reimbursement, you need to abide by.
Well, guys, I have no more comments or questions in the chat. Do each of you have a few closing statements that you'd like to leave us with? Dr. Economos, we can start with you. Anything just in general that some general?
Yeah, I mean, I really enjoyed the talks. I think the evidence that was presented is really compelling, from the individual level to the community level to national policy. And, collectively, if you put together what all of us said, you can really see how improvement could happen. I mean, I'm not suggesting we don't need more evidence and we don't need more science, as Dari was just saying, but there's a lot of really good evidence out there about what we should do from early childhood, through young adulthood. And it's alarming that we haven't really done this to the level that we have complete control over in order to improve the health of children. But, I know this science well, but really compelled by what you both showed. And in addition to what I showed, there's strong evidence, and we can do it. We can make a difference. And I guess I would just close by saying I'm fully supportive of national change, and I've worked at the national level on a lot of committees and policies. But when we can't get national change, we can get community change. And I demonstrated that, in a few different studies, and I'm working on it now. And I would just encourage everyone to think locally and nationally. So, work together to make both the bottom up and the top down change. And hopefully over the next 10 years, we'll see both happen. But, make that progress. And as you do local work, evaluate it, because it adds to the evidence base. And that will add to a push toward national change. So, all in this together. But I'm happy to talk with anyone about more local or community-based trials that can happen that would generate the kind of evidence necessary to push for national change.
Do we know, Doc, and I said that was the last question, but you stimulated some more thought. Do you know if there's evidence that schools that do not follow the guidelines, that they are having more problems in those areas or those districts? Is there any evidence that suggests that, or that,
Well, I mean, if you're not a school as part of the USDA reimbursement program, if you're an independent school, you can serve what you want. Okay. The studies that I've seen, now this is the published, evidence out there, have been highlighting schools that are independent schools that do a really good job. So I've never seen anyone go into an independent school or a religious school and then publish that the dietary intake is worse. I'm not saying it's not true, but that's what I've seen in the literature is really the bright spots of independent schools who've worked harder to make it better. But I don't know if either of you know about any that aren't.
Well, I would just add, probably the more interesting question is the parents who don't follow the guidelines. And so I'd be much more concerned about the school food from home, and studies from Tufts and elsewhere in our work shows that the food from home that the parents send there today compared to before the Healthy Hunger for Kids Act school meals are healthier on average than meals that kids are bringing from home. So they're bringing more soda, more junk food in their lunches when their parents pack them for them. So that's the real fight, is that parents think they're packing healthier lunches for their kids, but they're not. So that's the bigger concern than schools not following the guidelines, I think.
And Daria, if I could just add to that from an environmental perspective, because I was part of one of the studies from Tufts, the waste is higher. So, you can actually create a school lunch program with very little waste if you're reusing the trays and you're using things that are recyclable and you use composting. And if you look at the volume of waste that's produced by food brought from home, it's extraordinary. So in addition to the dietary component, there's a plastic and packaging and just massive amount of waste that occurs. So, there's two reasons to really think about food from school.
And I'll echo that. In the work that we've done in summer programs, the same is true. The foods that kids are bringing from home are less nutritious than the foods that are served at the camps when they serve them. So it's not just in schools, it's in programs outside of schools as well.
Yep. Yeah, we showed the same in after school programs. And when we gave a small reimbursement and systematized the way that they were serving snacks, there was transformation. Really often they need a small amount of money to get going, buy in bulk, but providing 1 to 2 servings of fruits and vegetables to kids in after school programs. And I mean a sport or Boy Scouts or 4-H or something like that. So there's a lot of other opportunities. And Daria, I think some of those were in your probably retail plus other category, where there's a lot of room for improvement.
Guys, I can't thank you enough. This was recorded, so for those who weren't able to tune in, we're going to be able to share that information with them. This was a bunch of jewels and bunnies that were dropped for folks to learn and take away. Hopefully we can use this information to educate the community, not just in Louisiana, but around the country. So thank you all for participating. Peter, I don't know if you had any closing remarks for the panelists, but you guys did wonderful. Thank you so much for taking out your time today.
Yep, thank you all. Very engaging. We very much enjoyed it, and look forward to hearing about your future research. Thank you all very much.
Thank you.
Thank you. You guys be safe.
Bye.